Okay, well, it looks like people are kind of set up, so I'll get us started. My name is Jessica Goodman. For those of you who don't know, I am the past chair of the Families and Health Special Interest Group. I want to welcome you to our webinar today. We have two very esteemed presenters, and this is an encore of a wonderful presentation that we had delivered to us at the conference this year in Boise, Idaho. The presenters are going to be speaking to us about going beyond patient and family-centered dementia care, the need to explore the multisystemic family terrain. We have Drs. Rolland and Podgorski with us, and Dr. Rolland is a founding member of CFHA, professor of psychiatry at Northwestern University Feinberg School of Medicine, and co-founder and executive co-director of the Chicago Center for Family Health. He is widely recognized for his conceptual model and clinical work with couples and families facing serious health conditions. And Dr. Podgorski holds a master's degree in public health and marriage and family therapy. She is a professor of psychiatry at the University of Rochester School of Medicine and Dentistry, where she holds multiple leadership positions. And she is interested in including family systems-oriented models of patient and family-centered care in dementia care. So without further ado, I'm going to pass it over to the two of them and allow them to provide us with what is a really important and timely, I think, topic in our healthcare system these days. Take it away, Drs. Rolland and Podgorski.
Okay, Carol.
Unmuting myself. Okay. So we have no financials, no disclosures to identify. And so what we're hoping to do today is talk about patterns of family functioning and how they can either support or impede dementia care. Talk about how important family relationships have been shown in terms of adopting the caregiver role and some of the important things that have to be done during the course that a family has to face during the course of dementia. And talk about what we think health systems really need in terms of family information in order to deliver responsible care to this vulnerable population. I'm going to start by just calling attention to the fact that dementia is really a family disease. Dementia is a general term. It's not a diagnosis. It's a general term for loss of memory, language, problem solving, and other things that are severe enough to get in the way of daily life. It is the most common cause. Alzheimer's disease is the most common type of dementia, accounting for 60 to 80% of cases. Vascular dementia is second. This is important to us because there are more than 6 million Americans living with Alzheimer's disease and 55 million living with dementia around the world. A lot of times people think of memory loss as not a big deal, and a lot of people refrain from getting treatment because they think it's just memory loss and all old people get memory loss. Well, we want to dispel that notion that dementia is much more than memory loss because it affects verbal skills, visual spatial perception, which gets in the way of things like driving ability. It affects one's ability to do abstract thinking, affects people's orientation to person, time, place, and other things. Attention span gets reduced. It affects personality. It can go in either direction, from pleasant personality to difficult, or difficult to pleasant, or any place along that continuum. It affects a person's ability to have reason or use good judgment. It eventually, because it's a brain disease, affects bladder and bowel control as well as motor function. And eventually, because the brain is responsible for controlling organs, it can lead to organ failure as the brain deteriorates. So you can see it's really much more than memory loss. It's also a family disease in the sense that if you have a relative who has Alzheimer's disease, your risk increases, and increases according to the closeness of your relationship to that relative, whether it's first degree, second degree, or whatever. And there are also genetic links to Alzheimer's disease some of the time. The duration of dementia can be 3 to 20 years, averaging between 7 and 9. So it's a family disease also, in the sense that, think about, as a family moves through time, all the things that happen in the course of a family over a 10-year span, all the people who come into or exit a family, all the life events that happen. So it really is a family disease. There are also incredible costs to caregiving. I won't go through all of these, but I just want to call attention to all of the costs of caregiving. It's not just financial costs. But speaking of financial costs, most families who take care of someone with Alzheimer's can spend between $5,000 to $34,000 annually. And there are about 6 million people with dementia and about 17.5 million family caregivers who take care of them, providing 17.5 billion hours of care, which is estimated to be about $256 billion of care that families provide. So with that backdrop, I want to turn it over to John to talk about the application of his multisystemic model to the care of people with dementia. John?
Thanks, Carol. It's nice to do this again.
Yes.
So I think I'm going to give sort of a family overview, and then Carol for about 20 minutes, and then Carol will come back and present. So I think one of the main things that in my work with any kind of chronic illness, but also particularly with dementia, is that families just lack a psychosocial map. There's, unless they have a family history and there's experience with it, they're sort of new to it. Next slide, please. So what I think they need in this realm, there's sort of 3 areas. One is having an understanding of family functioning, which includes, most models include beliefs, organization, and communication. A psychosocial understanding of the condition, because there's a lot of different types of dementia, and again, have very different patterns that have very different demands on families. And the other, because it's an ongoing process to understand developmental processes, which I mean by that is both the development of the illness, the development of the family system as a system or multiple systems, and then the development of each individual family member. Next slide, Karen. So this is the way I've developed the model, and this is just a way, again, of thinking about this. In terms of the illness, I think about the pattern of the illness, and so I think about things such as the type of onset, course, outcome, disability, and level of uncertainty. I think about various time phases, and then I think about the relationship between those two and the components of family functioning over time. Okay, next slide, please. So this is just one way of thinking about the pattern of illness. I mean, a lot, as Carol said, there's a lot of things that can cause dementia. But if somebody starts with a stroke or a traumatic brain injury, that's very, very different than something that could start gradually with just minor memory changes, something like Alzheimer's. The course can be quite different. Again, Alzheimer's being progressive. Things like stroke and brain injuries can be constant. In other words, there could be no progression, but they live with a kind of a constant level of disability. And then there's conditions like seizures and other things that can relapse. The other thing I think about is the kinds and levels of disability. We all know that in dementia, one of the common things is daily fluctuations, so that as it gets later in the day, the phenomenon of sundowning is one of the things that makes it more difficult for the affected person. It's one of the reasons I coach family members to, if they want to have substantive discussions with the members, is try to do it earlier in the day. And then there's the outcome, is it fatal or is it not fatal? And then the level of uncertainty around all this. Next slide. Again, I mentioned I break down illnesses into time phases. I think about this initial phase, which can be when there's symptoms, very common with, again, with dementia, where there's a long period of symptoms, but there's no diagnosis. Either it's not clear or the family member does not go to a doctor to have it checked out. And then there's a long haul of sort of living with it. And then there's a terminal phase, and there's transitions between these phases. Next slide. So as I said, there's often with dementia, it's common for it to be a 2 to 3 year period between symptom onset and medical evaluation. And one of this, again, some of the reasons I gave, but the other is that there's a very ambiguous boundary between normal and abnormal memory decline in an aging population. There's also denial and fear of a dire diagnosis, and the issues of stigma that, even though it's a biological condition, are still attached to people who are not cognitively functioning well. Okay, next slide, please. Okay, so some of the things in the initial phase, these are some of the things that families I find it's useful for them to master. The most important, and I've highlighted here, is that they define the challenge of dementia, in this case, in we terms, rather than it's my disease. Particularly when we get to caregivers, the we-ness, or being able to see the illness as something that all family members contend with in different kinds of ways, I think is a major way to help families live and do well with a condition like dementia. Okay, next slide. Next slide.
I'm trying.
Oh, okay. Sorry.
There we go.
Okay. The other part here that I've written about is how families live in the face of increasing disability. In something like, again, a progressive dementia, we often focus more on death, with a lot of illnesses, that there's anticipation of possibly a fatal outcome. My experience in working, and dementia is a very good example, is families are much more concerned about the loss of functioning, cognitive decline, and the suffering that goes with that. Again, conditions that can cause pain is another example where families struggle more with the disability and suffering than they do in the anticipation of death. Next slide. Because we're moving into this kind of genetic world, and also we know conditions that can increase the risk of dementia. There's the threat of future cognitive impairment. And it's quite different with conditions like Alzheimer's disease. There's markers where there's it's rare, but it's early onset, is like in the 40s, and it's progressive, and there's not much you can do to prevent it. There's other things like apolipoprotein E, which is much more prevalent in the population, but increases our risk somewhere in 7 to 8%, and it's later onset. So that's a very different type of genetic risk if one thinks about it. So I think we're moving into where there's much more markers that are going to mean different things. The other is a case I work with where people have REM sleep disorder. This has an increased risk of Lewy body dementia, which is similar in many ways to Alzheimer's disease. And I had one case where the husband had REM sleep disorder. He was tested every year. His wife was very frantic that her husband, any sign of memory, any kind of glitch, there it is, you have Lewy body dementia. It turned out the husband knew the risk, but sort of lived with, I'm going to live as well as I can for as long as I can. And if I get it, then I'll deal with that. The wife had grown up in a family where her father had Parkinson's disease that developed into dementia. And it was very, very difficult. So she was very focused on her husband and possible ways, signs that he was going to develop it. The other factor which came out when we did the work was there was some projection here, because she was really afraid for herself that she might genetically get what her father had and eventually develop a dementia. So again, I worked with this case for a while, but it's an example of where people have another condition. And in this case, the wife, who had a family history, really created the difficulties they were having as a couple. Next slide, please. Okay. So in the work I do, I think more about family-oriented consultations and when to time them. I think about prevention-oriented. I think about them at crucial transitions. I'll say a little bit more about that in a minute. And then I think about also psychosocial checkups, just like wellness checks. Some family members like the idea of just coming in periodically, once every 6 months, once a year, just to see how they are doing. So this is kind of how I approach it. Now, one of the things in terms of the dimension of time that I think is important, I think, what do people bring from their past experiences with illness and loss? And what type of illness, what kind of illness? I think about when is this landing in everybody's life cycle, their own development as family, as individuals, and then I think into the future. One of the things about past experiences, again, I'm looking for not just things that didn't go well, but also sources of resilience, of ways people handled a condition in the past. So it's not just an archaeological dig to find dysfunction. Sometimes it's very dramatic, though, where, again, a case where a person had a diagnosis of a skin cancer, was reassured that it was a skin cancer that could easily be treated. The wife became very frantic in the weeks afterwards, thinking her husband was going to die from cancer. It turned out in her family that her father had a misdiagnosed, this is a little different, misdiagnosed malignant melanoma and developed central nervous system complications when it metastasized. So there was cognitive impairment, but there was also a misdiagnosis. In this case, I called the dermatologist to suggest that he have another meeting with the couple, not for the patient's needs, but because the wife had had this experience. And I suggested, rather than waiting 6 months, that perhaps after a month or two, they could come in, just a very quick check to reassure her that everything was going well. On the other level, I think about, where does this impact people's life plans? So examples can include things like I had a teenager who was in his senior year of high school. His father had had a stroke and had dementia, and his grades started going downhill, and he felt very torn between his wish to leave home and pursue his personal dreams and his feelings that he needed to stay close to home to help his father and essentially take over the family. And also that if he left, he might never see his father again. Again, with a stroke, there can be a sudden change and somebody can die. Tends to be different than Alzheimer's, again, where people gradually get worse. So in this case, the difficulties this kid was having at school were very, very much tied into where he was in his development, and also the fact that the father had dementia. Another example real quickly was where I had a case where a family where the parents were in their 60s, the daughter had multiple sclerosis, but had developed cognitive impairment and moved home at the age of 40. There was one other sibling who was married with small kids. The parents had just retired. The father had osteoarthritis. And so you have this, think of all the life cycle collisions here that are going on. You have a woman who is 40 moving back home with a progressive condition. She never got married. She didn't have kids. She lost her career because of this. The parents are retired, moving into later life, and they have a window where they can do things, but now their daughter has moved home. The son has a family with small kids, and he's looking at, what's my role going to be with my sister, particularly, and what's my role with my parents as they age. So he's got not only his parents aging to think about, but also the fact that his sister, who's probably going to live probably much longer. So there were a number of different consultations here with different parts of the family, and part of it was coming up with plans and secondary plan Bs, depending on how this thing unfolded. But it's a good example where the daughter moved home and all these things came out in the family system at once. Next slide, please. Okay. So with these past, what I'm interested in is how did families organize around prior illnesses? What did families learn from those experiences, and what are learned differences among key family members? So again, when I get multi-generational information, this is really what I'm paying most attention to. Next slide, please. Okay. The challenge on a belief system level is how families create meaning for the illness experience that promotes competency and mastery. Next slide. It's very important here to think about ethnic, cultural, and spiritual beliefs. I have a list here of the things that I pay attention to: who's in the caregiving system, gender norms, kind and degree of communication. Those are all things, and again, because we work with families where there's split ethnicities, in these situations, profound differences can emerge in the context of an illness experience. Next slide, please. Okay, communication. So conditions like dementia, test us, we need to stretch our envelope. So this is this is just a way to visualize that. Next slide. So one of the things that's unusual with, or not more unusual, I think, in my experience, and with dementia, is that the disclosure to patients, I mean, you can see with heart disease and cancer, it's very high. With Alzheimer's, again, there's different figures given here, but the bottom line is it's much lower for both the patient and the caregivers. And some of the reasons are given below: the lack of effective treatment, fear of upsetting patient and family, high severity at the time of diagnosis. So again, it's worth finding out what's been communicated and who's been communicated to. The next slide. Clearly, with a condition like dementia, it's very, very, very important to have early communication around advanced directives, proxy decision-making. The problem with dementia is deferring, unlike, let's say, cancer, deferring communication. There can be gradual or a sudden shift, like with a stroke, or a very gradual shift, and then one day the person with the condition no longer is able to communicate about important issues. So I'm much more directive, so to speak, and in these situations, also around the issues of secrecy and denial. If there's relationships that need repair and reconciliation, I've had very good experiences across a range of chronic illnesses, but in this situation, again, because of the time pressures, potentially, I'm much more urging that if family members have things they want to talk about, that they do that now, not wait. Next. Beliefs about etiology. I always say, ask each family member if they have any explanations for the illness or what contributed to it. If there's self-blame or blaming another family member, that's almost surely a reason for a referral, because that's really problematic. If a person says, well, you drank, you smoked, and now you've got dementia, I warned you about this, and now I'm going to have to take care of you, and I'm going to be miserable. So I'm saying that it's very useful to ask, and be sure to ask each family member. Next slide. I'm always curious who will be included and excluded in these discussions, what topics are off limits, and why. A very simple task to give families is to ask family members to write down a list of things they would like to talk about that they haven't, and things that they think they shouldn't talk about because it will really affect the other person or damage their relationship. It's wonderful when people share these lists, because often they're very, very similar, and dispels beliefs about, well, I wouldn't want to talk about that, I wouldn't want to hurt you. So it's a very simple thing to do, and it gives families a starting point about topics that they all are willing to discuss. As with other chronic illnesses, there's really no evidence that children are hurt by age-appropriate information. If a kid asks a question, they need some kind of answer in an age-appropriate way. It's clear that block communication is associated with all kinds of difficulties. Next slide. It's also important to ask about adult children's own nuclear families. I think we get very happy when we say, oh, well, we got all the kids together to talk about it. Well, these are usually adult kids and they have their own family systems. And like the case I mentioned before with the sibling who had his own wife and kids, the spouses of the adult children may very well have their own aging parents. And so there may be more than one set of aging parents and issues, and there may be small children. So it's very useful when you're meeting is to bring these things out into the open early on so that they can be taken stock of. The issues of equitable role functions, I think, were gender issues often come up in this. Geographic location, because we're a very spread out society. It's very, very valuable to try to find roles for each family member. You know, when my father was aging, my brother lived close by. So I took care of a lot of the medical stuff. You know, I mean, there's ways of divvying up the turfs so it's fair to everybody. The other thing is a periodic review in relation to these possible transitions in the disease or in life cycle. Next slide, please. The couples challenges, again, this is a whole separate area. He's not the same person anymore. You know, that statement is profound. Again, it may be long, long before the end of a dementia. The fact is that the spouse or partner is in a much closer range and has a different kind of relationship, may have a very different relationship than adult sons and daughters. So, and where family members may come and say, oh, Joe's great, you know, he seems like his old self. And the spouse is thinking you don't live with him 24/7, you have no idea. And can feel shame at bringing it up because they're the outlier who's, you know, the party pooper, so to speak. You know, well, I don't experience him the same way. Things that can help are highlighting strengths and unaffected areas of the relationship, emphasize less cognitively oriented interests, music, taking walks. It's also important to inquire about the well spouse's unmet needs. This very often gets lost, and with progressive loss of functioning, the well spouse often is struggling with continuing to invest in revising the definition of their intimacy. Now, I'm not just talking about sexual intimacy, their intimacy on all levels, or redefining the relationship as basically a caregiving one. And at some points in this, it's often a great relief to the spouse or partner to have permission from us. So maybe it's become more of a caregiving relationship, and that's really what you've got now, as opposed to keep trying to do something and revise the intimacy in a way that becomes more and more difficult. Sexual desire and functioning often remains intact in the person affected by dementia, and that it's a longer conversation, but it's often very, very difficult for the well spouse because in many ways they may not feel attracted that way to their partner anymore. On the other hand, they say, well, that's one of the few things he can still enjoy, so I feel badly that I'm denying him that. So again, it's more the inquiry about these things that I think are important. Some of these things obviously would, if you're a primary care doctor, you're not going to be able to perhaps deal with all these things, but asking is a profound intervention because it validates the experience of of the spouse in this case. And you can use referral there to a behavioral healthcare specialist with, you know, medical family therapy skills, in my opinion. Next slide. The other thing is I just want to say before I stop, grieving losses. With dementias, losses accumulate in little bits over time. It's not, again, the loss of the person often is long before the death of the person. Pauline Boss, in her work on ambiguous loss, has written extensively on this. But there's not really normative rituals for this, and often not acknowledgement by healthcare providers. So even though Joe is doing well, he may still be dealing with losses, and the other family members are living with those losses, or the person with dementia is also experiencing themselves, losing themselves, so to speak, and their whole identity changing. So I think, again, asking about this is important. Often, again, the spouse and other key caregivers are in positions of feeling isolated. In other words, there can be people that further out in the concentric circles who are not in on things as closely and don't experience this. So I'd like to think about that people are at different levels of experience here. I think it's my last slide coming up. Again, watch for exhaustion. Stamina is an issue because these are long-term illnesses, and sometimes people do better than expected. I've had cases where people did better, and that was much, much more difficult for the family or the couple than if there was a diagnosis given with a 3 to 4 year life expectancy. So the longer this goes on, the medically, it can get more difficult. Last slide. I think, is there another slide? Yeah. Again, I don't have time for this, but the need for professional help in the home, long-term placement, those are all major transitions, and they need consultations and what is the meaning to the family. Again, cultural differences are huge here, where some families, in some cultures, you take care of your family member to the very end. And so it can be very difficult when a condition like Alzheimer's is just beyond the reach of what a family can deal with, particularly spread out families. We're not in little old, villages like the old days were. So I think I'll stop at that point and turn it over to Carol.
Okay. So I love listening to John talk about this because we are kindred spirits in how we see this. And the other thing is we both are situated in specialty care, which is, different from where a lot of people see families with dementia. And we have the luxury sometimes of getting to know families a little bit better. So unfortunately, the multisystemic approach is not always the norm in primary or in specialty care. So from my practice, here are a couple of things that I've heard from families over the years. My mother left us when we were young, and now she expects me to take care of her. I'd like to know if my husband's dementia was caused by years of alcohol abuse. If it wasn't, I won't have a problem caring for him. But if it was, we got along fine until my wife had to stop drinking due to a medical condition. Then she was diagnosed with dementia. My husband had an affair for the past 20 years of our marriage. So you can see all of these things map onto those things that John were saying, that the context of the family matters a great deal into affecting how a caregiver is going to walk up to this responsibility. So I'm going to present a case in a minute, and it's a case of a patient's experience of feeling unsafe following a dementia evaluation. It also looks at a family caregiver using dementia as a way to get out of a bad relationship. And it highlights family dynamics and consequences that are often unaddressed in the healthcare setting. So I want to talk about Jack, a 68-year-old white male, and he was diagnosed with mild cognitive impairment and depression. He had a history of past and present alcohol dependence, history of obesity, diabetes with circulatory symptoms and wounds. And he recently had a motor vehicle accident that manifested in a leg injury that led to a disability. He also was impulsive, had a lifetime of risky behaviors, a DWI, a couple of accidents. Regarding social issues, Jack was married, lived with his wife and 2 adult stepdaughters. He had a verbally abusive relationship with his wife. It was kind of bidirectional, and close relationships with his stepdaughters. They live in a rural community. He was an auto mechanic by trade, but retired early because of the disability, which rendered him financially dependent on his wife. Jill, a 59-year-old white woman, relatively healthy. She did have a history of osteoarthritis and a recent total hip replacement. She also had some alcohol misuse and occasional binge drinking, was also impulsive and adventure seeking, and had some narcissistic personality traits. Again, she lived with Jack and 2 adult daughters. She owned the home they lived in, as well as several acres of land, and she co-owned a successful advertising business. And legally, she was Jack's healthcare proxy and had power of attorney. So relationally, they met 12 years ago in a biker club. They shared the love of the open road. They loved adventure and socializing and music and going out, and really hit it off and got along really well. They married about 10 years ago. Jack moved into Jill's home with Jill and her daughters. Then he had the motor vehicle accident, which led to the leg injury, disability, increased alcohol use, and then financial and dependency on Jill for activities of daily living and instrumental activities of daily living. Jill continued to experience success with her career, and she saw herself moving from the open road to a life of changing bandages. So there were some power shifts in their relationship. Jill was increasing power as Jack became more dependent on her, and the power shift led to conflict and abuse. Jill began to look for a way out and decided to focus on Jack's memory impairment. So when he was seen at the memory care program, his treatment plan goals were, firstly, he was diagnosed with mild cognitive impairment, with short-term memory loss being the most significant feature at this point. His Montreal Cognitive Assessment score was 24, which rendered him still pretty functional cognitively. The physician prescribed donepezil and sertraline. Donepezil is the generic for Aricept. You see a lot of ads for that, and sertraline, of course, is the generic of Zoloft. There was a recommendation that Jack stop his alcohol use because it was going to interfere with the medications and really render them useless. They recommended that he change his dietary habits, increase physical activity, socialization, and cognitive stimulation. But of course, you have to understand he's no longer driving and living out in a rural community by himself. And they also recommended that Jill get some education about dementia and support. So how did they respond to these things? Well, Jack's response was, I didn't know she was bringing me here for this evaluation. And then he later confessed, I'm afraid of what she told the doctors about me, and I'm scared she's going to put me in a home. Okay. Jill's reaction to the diagnosis and recommendations, I'm tired of taking care of him. Between the wound care and fighting with him about doing PT exercises. And now they want me to stop him from drinking, and I don't have the energy for that. I want to put him in a nursing home and move out of town and get on with my life. Jill was under this preconceived notion that because she had power of attorney, she could do anything she wanted with Jack. So she said, I thought POA gave me authority to do that. So Jill didn't really understand that POA didn't really go into effect until Jack didn't have the wherewithal or capacity to make his own decisions. So she was very upset with the healthcare providers and pretty much was very dysregulated at that time. So let's move away from the case for a second and move toward thinking about person-centered care, which in the basic Institute of Medicine definition is being respectful of and responsive to individual patient preferences, needs, and values. It's designed to honor patient and family choices, include them in decision-making, sharing timely, accurate information, and trying to collaborate across care settings. Boiling down family-centered care, it's developing and implementing patient care plans, I want to punctuate that, with family participation. So when we look at how care is usually provided, if we look at the top as the social ecological model for the patient, and the bottom encircled by the purple circle as the caregiver's social ecological model, we can see that most of what those care recommendations were focused on Jack, his patient-centered, it was a patient-centered approach, and Jill's factors weren't really taken into account. And usually the care plans that we do are, how can we mobilize the family to address what the patient needs? And you don't hear all of those things that John was talking about in terms of what the caregiver needs. So what's missing? An acknowledgement of the family caregiver's biopsychosocial needs, and really an assessment of how family relationships and behaviors, health of family members, and what kind of resources they have may affect the person with dementia's well-being. We don't really ask about that very much. So we know from the literature that family function matters. And there have been studies, especially in dementia, that show that when families function poorly in terms of problem solving, communication, when they don't have secure attachments, that it increases caregiver strain and burden. We also know that when there's high relationship satisfaction, there's less reactivity and burden, and it results in better problem solving, which eventually ends up in better health outcomes for both the person with dementia as well as the caregivers. So family relationships matter. Some of the things that get in the way, I'm sure John's seen this, I know I have, are family favoritism. It comes, how parents have treated children, or how children perceive their parents have treated them, affects how they choose to become caregivers. Elder abuse in dementia is very common. For example, psychological abuse, the studies that have been done show that psychological abuse is present in like 30 to 60% of cases of dementia. Physical abuse between 3 and 23%. Neglect 20%. That's 1/5 of all of those 5 million cases, right? Financial exploitation, 15%. And then in Dong's study found that multiple forms of abuse were present in 1/3 of families with dementia. So we also know that the person with dementia can be abusive. I always say that their families don't always look like those sweet couples in the Aricept ads. They come in all shapes and sizes. So family caregivers, 35% report verbal abuse and 6% report being physically abused by the person with dementia. So family relationships can create these power dynamics that lead to a misrepresentation of patients' wishes. They can lead to elder mistreatment, like in the case of Jack and Jill, or family violence. So I'd like to talk about something that I developed that I'd like to call the family framed approach, as opposed to patient-centered or family-centered. In the family framed approach, this more represents what John was talking about, that the person with dementia has their own social ecological system and biopsychosocial needs, but so does the caregiver. And what we really need to do is look at the relationship between the two, and that's what John described so beautifully in his presentation. And we just don't see this happen for most diseases and in most care settings, where we really understand the biopsychosocial needs of each, but then go one step further and understand what their relationship dynamics are between the two. And in dementia, this is really critical. So what are the theoretical foundations of this? Well, the first, of course, is family systems theory. And I'm not going to go through all of this because I know the people on this call understand generally that we just know that you can't understand a whole system by understanding just one person in the system. And we need to understand how families are structured, organized, and what the transactional patterns are that shape the behavior of the members. The second is that every family member has a distinct ecological system, even though there may be a fair amount of overlap. The goal of family framed care is for healthcare providers, as well as human service providers, the care managers and social workers and people from area agencies on aging, for example, to know and understand that the person with dementia and family caregiver need to understand that within the context of their family relationships, in order to develop a plan of care that meets the biopsychosocial needs of the patient, considers the needs and wishes and resources of the family caregiver, so that the plan will be feasible, likely to be implemented, and to promote the safety and well-being of the person with dementia and family caregivers. We often hear also now in the context of the age-friendly health system, the focus on the patient's needs and wishes. We all want to honor the patient's needs and wishes, but when the patient's needs and wishes involve a lot of effort and resources from someone else, it becomes relational, and it goes definitely beyond what the patient with dementia needs. It has to be feasible. So the skills that are involved in really understanding how a family system, when understanding what a person's family system looks like, how those family relational dynamics affect the lived experience of dementia for everybody in the family. In healthcare systems, we often assume close, trusting relationships. When a family comes into care, into an encounter, a medical encounter, sometimes in dementia, whoever the person is who walks in is put in the chart as the person who's the caregiver, whether they have healthcare proxy, power of attorney, whether they have any authority whatsoever, they're often identified as the informant. And we're not sure that's always the best person to represent the needs and wishes of the patient. And we often don't ask the patient about that. So the next skill would involve proficiency in administering some kind of family assessment to understand the strengths and resources that John described so well. Often in the electronic health record, the only family or social history that's populated is smoking status, and I think we need to do better than that. Another skill is to know when to refer the patient or family caregiver for behavioral health services or family therapy. We need to clarify the reasons for the referral for behavioral health service or family therapy. And another skill is to evaluate the needs of family caregivers to determine if they are willing, capable, and have the resources needed to provide the care required to support a care plan, as well as being mindful of their own health and well-being. We don't really do this generally very well. So I want to go back to that point that we can't just assume that the informant is the caregiver or the healthcare proxy. Sometimes it's just the daughter that has Tuesday afternoon who's bringing the Tuesday afternoon off, who's bringing the person into care. So we have to understand those relationships. And we have to dig a little deeper to understand what those relationships are and if the person there can really represent the patient's best interests. So my last slide is just thinking about, could the clinic team have done something differently to protect Jack? And is biopsychosocially oriented care possible without understanding a family context? We know, especially in primary care, that you have very little time to understand, to really get to know the dynamics of a family. In specialty care, we have a little bit more. So what would the minimal information be that we need to understand about people in order to at least identify a red flag so that we might have figured out that Jill had different ulterior motives, right? How could we have picked that up? And how can healthcare professionals gather important information while adhering to privacy laws? What can they document in charts? What do time constraints allow? I know this is a big lift, but I often have seen the advancements that have been made in gathering information about social determinants of health and documenting them. And personally, I believe that family relationships are also an important social determinant of health. This is just a model. I'm not going to go through the whole thing, but it's examples of family framed approaches to care. And I want to just read the patient-centered one and have you just think about Jack and Jill, okay? So with patient-centered care in a family framed model, you'd think about assessing the extent to which Jack could provide accurate and reliable information, right? What could we ask Jack about his health, memory, and function, and how he feels about being in this visit? What are his hopes and fears for the visit? Is Jack comfortable with the accompanying person, Jill, answering questions about his health, memory, and function? If not, who does Jack think would have been a more appropriate person? Does Jack have a healthcare proxy or power of attorney? What does Jack expect from the appointment? And how can the physician and staff be helpful? And this is an important one. Is Jack comfortable with the family member being in the wrap-up session and discussing the review and reviewing the plan of care with him? This is like an informed consent process. And as we've made strides in dementia care to get people diagnosed sooner, many people have the capacity to answer these questions, but we have an old paradigm that says somebody must speak for them. And I'm going to just stop there because I would be curious to hear what other people have to say.
All right, thank you two so much. Max Subotsky entered in the chat, great case example. It also raises a major gap in healthcare conversations where we don't assess the motivation of family members wanting to be a caregiver for someone with memory loss based on intergenerational factors. And then also from William Gunn, we have, when and how do you use neuropsychological evaluation and consultation, particularly when the person is declining but might deny that there's a problem?
Do you want to take that one, John, to start?
Which one, the second one?
Yeah, I agree totally with what Max had to say. It is.
Yeah, I mean, I think if a diagnosis is ambiguous, there's more rationale for the neuropsych testing. If it's mild cognitive impairment, I mean, again, you have to know what are the implications for that about how people are going to take, maybe ambiguous results. I had one case of a man where the physician and neurologist agreed it was not Alzheimer's disease. It was a mild cognitive impairment, but they did the psychological testing and it was a 10-page report. And in the middle of this, it says somewhere there's a phrase consistent with Alzheimer's disease. And he saw that and he went ballistic. I mean, it didn't matter what the physicians had said. And I had to navigate that because the psychologist was doing his job. He was putting in a differential, but there had been not adequate communication between the psychologist, the neuropsychologist in this case, and the rest of the healthcare team and what had already been communicated. So I think it can cut both ways. I mean, there's certainly a role, but once a diagnosis has been made, I'm not sure at that point, that may serve more research studies and other things going on in a medical center.
Right. I would like to just add to that question about neuropsych evaluations and diagnoses. There are a lot of people who are declining and they have no insight that something's wrong. But a lot of times if you work with them, you can get them to identify something that isn't normal, whether you call it word finding or whatever they are willing to accept. And sometimes the treatment options don't really matter. So as long as you can call it something, whether it's forgetfulness or if the person's willing to even go that far, it unleashes the family to be able to have conversations. It's when they deny everything that you can't have those conversations. So if someone's willing to accept forgetfulness or aphasia or something else, I tell the family it doesn't matter. They don't need to know they have Alzheimer's disease because that's not going to change it. As long as you can call it something, you can work with it.
Okay, that's great. So Maggie Smith, this might be our last question we have time for. Are there certain conversations that are more appropriate to have with only the family caregivers, or are there conversations that should be avoided in front of the PWD, either in a primary care or family therapy setting?
Right. I think it depends. There's a lot of variations on this question, so there's not a one answer. I think, if it's advanced disease, there's becomes more and more a rationale to have some separate conversations. I think a good family-oriented assessment at the front end, so you get at what are the implications of communication and between different family members, is important. I think there's situations, and again, Pauline Boss in her work on ambiguous loss has written eloquently about this, where too early family members are bypassed. Questions are no longer directed to the person with dementia, or other family members are answering for him and her. So I think it's important, one has to know, what does that mean? What does that mean in the baseline of that family's functioning? How severe is the dementia? All those things become important in that. So it's a great question. It's just that there's not one answer.
I would add psychosis,
John.
John, I would add psychosis when there are cases of psychosis or Capgras syndrome where a patient when the person with dementia doesn't recognize the caregiver as who they are. Those are conversations that definitely one-on-one would definitely be better. When someone has a different reality, totally, I think that's an important time to have separate conversations.
Yeah. I was looking at Max's question about family members wanting to be. I mean, there's a lot of power issues embedded in that. I mean, inheritance, there's all kinds of things that can go on in that process that I think, unless one understands the baseline of that family, you don't know what that means. I mean, again, it can be gender-based. I mean, it can be a lot of quote unquote normative reasons, cultural reasons, but there can be these other reasons that have to do with, who's going to get what later on, or even seeking affirmation. I had one case where the daughter who took care of, wanted to take care of her mother, was the one who had not been affirmed by the mother. The other two daughters had been affirmed in their lives. And so there was wanting the validation of you're a great daughter, you're taking care of me. So that can come into play too.
Oh, this has been a wonderful conversation. Thank you both for sharing your knowledge and expertise with us. And thank you all for joining us today for this excellent presentation.
Thank you.
I hope you all have a great day.
Thank you.
Thank you.